สวัสดีครับ Good morning, good afternoon, and good evening, ladies and gentlemen. I'm Puvanai P from San Francisco Hospital, Ubon Ratchathani, Thailand. Today, I will talk about the resectability assessment in Perihilar Cholangiocarcinoma. Okay. This lecture I talk uh, at Lampang Hospital on 6 June 2024. Okay, so I want to share with you about my thought on resectability assessment in perihilar cholangiocarcinoma. We know that surgical resection is only chance to cure for the patient with perihilar cholangiocarcinoma. So, resectability assessment is the most important steps of the treatments to classify the patient, which patient is get benefit from resections or which patient is unresectable, no need for surgeries. Okay. Our data for 6 months, we collect the data from January 2015 to June 2015. My hospital in the surgical department had a patient with cholangiocarcinoma about 352 cases. Okay. Unfortunately, just only 1/3 of the patients we classify it in resectable case, but 2/3 of the patients is unresectable. And we found that the survival outcome is different, very different. For unresectable case, the median survival time is only 3 or 4 months. But in resectable case, the median survival time is about 15 to 20 months. Okay, this is the difference. And we collect the data in our hospitals for 2015, 2013 from 2018. The patient with cholangiocarcinoma who underwent export laparotomies, we found that in 720 cases, we export laparotomies, just only 80% of the patients we found it resectable, but 20% when we explore laparotomy, we found that it's unresectable. So in the all-of case in my hospitals, just only 1/3 or 30% of case is unresectable, and the survival outcome for the patient with resectable and unresectable is different. For the patient with curative intent resections, we had 5-year survival, but for palliative intent and unresectable, the survival outcome is very poor. And if the patients underwent curative resections, R0 resection is better than R1 and R2 resections for any state, okay? In state 1, state 2, state 3, state 4, it's different in survival outcome in every type of cholangiocarcinoma, okay? So resectability assessment is the most important steps. If the patients can perform curative intent resections, the patient will get the longer survival than the patient with unresectable. This is the most important concepts for the persons who in charge with the policies of screenings. Okay. Professor Noron Kantikau, the most important persons in my country to fighting with cholangiocarcinoma, he published the data of CASCAF data, and he found that the patients in screening case, in early case with the screening programs, had a better survival outcome than the patient with walk-in patient. It means that the patient with a symptom and walk into our department and perform resection. The survival outcome is significantly different between two groups. It means that if we can get the early case of cholangiocarcinoma and perform surgical resections, the patient will get a benefit of the resection and had a longer survival than the patient had the symptoms and come to our department. Okay, so resection is only chance to cure, And resectability assessment is the most important factor in most important steps to clarify the patient benefit to resection or not. Okay. But do we speak the same language in resectability? This case is resectable or this case is unresectable. We talk the same language. I don't know. The first language is about diagnostic and classification. We talk the different language about diagnostic and classification. Most of centers worldwide and most of the literatures nowadays classify the patient with intrahepatic cholang, perihilar cholang, and distal cholang based on the classification of John Hopkins in this paper. Okay, if the patient's tumors located in intrahepatic and just only perform liver resections, we classify it intrahepatic. But if the patient performs liver resection plus hilar resections, we classify it perihilar cholangiocarcinoma. Is this true or not? We know that cholangiocarcinoma has different classification. If you look at the histological classifications, intrahepatic cholangiocarcinoma we classify into small duct type, large duct type, okay? And if we look at the morphological classifications, we can divide it into more mass-forming type, periductal infiltrating type, or intraductal growth type. And if we classify it in anatomical classifications, we can divide it intrahepatic cholang, perihilar cholang, and distal cholangiocarcinoma. There's a lot of classification and there's a lot of difference type of cholangiocarcinoma. I will show you the case. This case has the tumor in the perihilar region here. Okay, it is a intraductal growth type tumor. And this case, the tumor is here in perihilar regions and thickening of the bile duct. It's a periductal infiltrating type. Okay, and this case had a mass here in the hilar regions. Okay. The last one has the large mat here and involve the hilar region here. Okay. So we have four types of case. The intraductal growth type in the confluent here, the periductal infiltrating type here, and the tumors here and involve the hilar region here. And the tumor growth this time from the hilar region, but it involved the hilar here. Which one is perihilar cholangiocarcinoma? Do we talk the same language about the definitions? Okay. For my centers and myself, I used this proposal from Professor Ibata, Japanese Nagoya group. Okay. If the tumors located here in the confluence of the bile duct, we call it perihilar cholangiocarcinoma. But if the tumors is the mass-forming type, we have a numerical classification here. This is the bifurcation of right anterior and right posterior portal vein. We call it P point. And this is the umbilical portions point, Q point on the left side. If the tumor is mass forming and the center of the mat located here in the Q point and P point, we classify it in perihilar cholangiocarcinoma. Okay. But if the center of the mass distant from the U point and P point, just like this, we call it intrahepatic cholangiocarcinoma with hilar involvement. Okay. So for the case I show you, perihilar cholangiocarcinoma is this case, but this case is intrahepatic cholangiocarcinoma with hilar involvement. Okay, this is we will talk the same language before we go to the resectability assessment and we discuss about the outcome of the treatment. Okay. So about the resectable and unresectable, do we talk the same language? Okay. I will show you my thought about resectability assessment and my step about resectability assessment, okay? The first thing we must talk the same language about resectability is that resectability can divide into two groups: technically resectability and oncological resectability. Some centers will say it's biological resectability. Okay, technically resectability, it means that for perihilar cholangiocarcinoma, you must achieve arterial resections by technically resectabilities, and you must maintain the biliary enteric flow for the patients and preserve vascular inflow and outflow. Okay, and after you resect the tumor and the liver must adequate future liver lumen for the patient. Okay, this is technically resectability, but the endpoint of the treatment is to increase survival. The treatment should not offer for the patient just only technically resectability, technically possible. Okay, so the resectability, the importance of resectability assessment is that oncological resectability. We must be concerned about the oncological resectability. Okay, so my step of resectability assessment is that I must concern about three factors. Okay, the first factor is the patient. The second factor is disease factors. The third factor is liver factors. For the patient factors, the patient must fit for surgeries. If COX score is the best, and the patient can walk and do the routine practice, routine activity by themselves, something like that. Okay, the patient factor is an important factor. The first thing you must concern. After that, if the patient fit for surgery, we will look at disease factors. Okay, I divide disease factor into two category: distant metastasis and local regional disease. Okay, for distant metastasis, okay, we will look at the organ metastasis, peritoneal metastasis, and lymph node metastasis. For organ metastasis, we will look at the lung metastasis, liver metastasis, or not, something like that. Okay, but there are some debatable issues about the distant metastasis because surgical resection is only trying to care for the patients. There's no effective adjuvant treatment or systemic treatment for the patient with perihilar cholangiocarcinoma. So about the distant lymph node metastasis, I mean, lymph node group 16 and group 9, we call it distant lymph node metastasis, but lymph node group 12 or group 8 or group 13, we call it regional lymph node, okay? So distant lymph node metastasis, it means that lymph node group 16 and group 9, okay? The data show us that if the patient has no distant lymph node metastasis, the patient get benefit from resections. But if the patient has grossly lymph node, distant node metastasis, it's not good for surgery. Okay, the surgical resections equal for palliative treatment. Okay, but for the patients in the middle, there's a micrometastasis of the lymph nodes. There's some roles of resections. If the patient fit for surgery and you not perform the aggressive procedures, just only resection and other resections, the patient young age and fit for surgery, no other poor prognostic factor. Some literature and some practice suggest that if the patient had a micrometastasis of the distant lymph node metastasis, it's got a benefit for the resection, okay? Because of we don't have the effective adjuvant treatment, okay? For the peritoneal metastasis, This is the paper, the interesting paper from Japanese group. Okay. We collect the data of the patient with peritoneal lavage, and we found that if the lavage positive patients, okay, and they perform liver resections, the survival outcome is equal. It's equal compared with the patient with no peritoneal lavage positive. This paper told us that if the patient is early case and early metastasis to peritoneal seeding, there's some benefits of resections. Okay, then there's there's role of resection in this patient. Okay, and we talk about the intrahepatic metastasis. This paper from Nagoya group, we divide the patient into this is resectable, this is unresectable case, this is resectable case, and they look at the pathological report. This is occult metastasis. It means that they resect the patient and pathological report its occult hepatic metastasis. They show that this is the no metastasis. This is the occult metastasis. This is the obviously metastasis. If the patient has occult metastasis, the survival is better than unresectable, obviously metastasis and palliative resection. Okay, but it's not good compared with the no metastasis. This paper told us that if the patient fit for surgeries and just only micrometastasis, intrahepatic metastasis, there's roles of metastasis in the patients. Okay, so for the distant metastasis, for my practice, I think that if the patients have micrometastasis from the lymph node, distant node metastasis, if the patient fit for surgeries, there's a not aggressive procedures, just only liver resection and bladder resections, no pathogen vascular resections. I will proceed, I will go on surgery, yeah, give the resection for the patients. And if the patient fit for surgery and just only one peritoneal seeding near the tumor, if the patient fit for surgeries, I will give a chance for the patient to perform resections case by case. Okay, this is my thought from the data nowadays. Okay, and for the patient's resectability assessment, if the patients have no metastasis, okay, we will look at the local regional assessment. Okay, the step of assess local regional assessment, we will look at the disease extensions, vascular invasions, and regional lymph node metastasis. Okay, for disease extensions, we will look at the disease we can achieve arterial resection or not in this case. Okay, arterial resection, I mean that distal margins and proximal margin. Okay, distal margins here, we can achieve arterial resections by just only bladder resections or not, or we must perform HPD in this case. Okay, and for proximal margins, we need adequate resection margin to achieve arterial resections. Okay, for example, in this case, okay, the tumor is here. This is intrahepatic cholangiocarcinoma enrollment. Okay, but it's easy scale to show you to assess the resectability. Okay, the tumor is here. This is middle hepatic vein. Okay, if you want to perform liver resection plus bile resections, the margins we're concerned about the ductal margin here. Okay, this is ductal margin, and this is parenchymal margins or radial margins. You must concern two margins, two types of the margin. For proximal margin, you must concern radial margins and ductal margins. Radial margins, it means that it includes parenchymal margin, vascular margins, and hilar soft tissue margins. Okay, there's some literatures compare between radial margin and ductal margins. It shows that radial margin and ductal margin had the same survival outcome. Okay, and our data show the same results. For R0 resections, it's better than R1 resections. And for R1 resection, radial margin and ductal margins, it's the same survival outcome. So you must concerns about radial margin and ductal margin when you perform resection in perihilar cholangiocarcinoma. Okay, and how the distance of the resection margin from the tumor we must achieve. There's no literature talk about the radial margins, how wide of the radial margins. I use the data from the mass forming type cholangiocarcinoma, intraductal cholangiocarcinoma. Okay, I prefer 1 centimeter from the tumors for radial margins in the perihilar cholangiocarcinoma. For the ductal margins, okay, the first step, which how far, how wide of the margins we can use to achieve R0 resections. The literature from Nagoya group show us that 1 centimeter we can achieve R0 resections. Okay, no chance for invasive carcinoma, but carcinoma in situ, we must need 2 centimeters to get rid of carcinoma in situ. Therefore, for my practice, 1 centimeter is adequate for achieve R0 resection. But to improve survival, we know that in early cholangiocarcinoma, carcinoma in situ is a bad prognostic factor for early case and for superficial spreading cholangiocarcinoma. So in early case, 2 centimeters, it's good for the patients. However, for poor prognostic factors, the margin is debatable. Okay. For our series of the patient with perihilar cholangiocarcinoma, we found that R0 resection is the best thing for the patient, and lymph node metastasis negative is the best thing for the patient. But R0 resection and lymph node negative, which one is the most important factors for the patients? For Japanese group, they found that for lymph node negative patients, R0 resection is better survival outcome. But in our lymph node positive patients, resection margin status is not different. Okay, R0 and R1 had not different survival outcome in lymph node positive group. As same as our series, we collect the data of perihilar cholangiocarcinoma and divide into two groups, lymph node positive and lymph node negative. We found the same results. In lymph node negative group, R0 resections had a better outcome than R1 resection, but in lymph node positive group, R1 and R2 has the same result in survival outcome. Therefore, for the patient with poor prognostic factors, surgical margin is not different. So I think there's a role of neoadjuvant treatment in the patient with lymph node metastasis patients. Okay, so the step we look at the step of the resection assessment. Okay, patient is fit for surgery, and disease factors, no distant metastasis, and for local regional assessments, the disease extensions. Okay, if the disease extensions we can achieve R0 resection is the good thing for resectable. Okay, and for the next step is vascular resections. The vascular resections in perihilar cholangiocarcinoma, we will look at the feasibility and the benefit. Feasibility is mean that it's safe for surgeries. Okay, there's no morbid mortalities. Okay, and the benefit is a survival outcome. Okay, for perihilar cholangiocarcinoma, we will deal with the portal vein and hepatic arteries. Okay, for portal vein resection and reconstruction, we have a lot of literature review that the feasibility and the benefits of vascular resection is acceptable, okay, for portal vein resection. But for hepatic artery resection and reconstruction, it remains under debatable, okay. For the Japanese and Koreans literatures, they said that it's a benefit for hepatic artery resection and reconstruction, but for the Western countries, some literature, some centers say that it's contraindication for the hepatic artery resection and reconstruction. So this is remained under the debatable issue, okay, for the resection of the artery. For my practice, I will select case by case. If the patient fits for surgeries and there's no poor prognostic factor, for example, lymph node metastasis. If the patient's hepatic artery involved by the tumor, not the lymph node, I think it's a benefit for undergoing hepatic artery resection and reconstruction. Okay. So the next step is the regional lymph node metastasis that I previously said to you that I think there's roles of neoadjuvant treatment in the patient with regional lymph node metastasis because of R1 resection and R0 resection is the same survival outcome. Okay. And after we assess the patients and disease factors, we will decide to perform liver resections, which type of resections you must perform, okay? And after that, you will look at the liver factors. You must evaluate the quantities and qualities of the livers, adequate feature development or not. And if there's not adequate liver feature liver remnants, PVE, it's mandatory to perform. Okay, the one thing that I will talk to you is that post hepatectomy liver failure impact the survival outcome in our series. Okay, we collect the data in our series for 5 years and divide the patient into two groups. Okay, post hepatectomy liver failure and no hepatectomy liver failure. We found that if the patients experience with post hepatectomy liver failure, this group of the patient will has a poor outcome compared with no post-hepatectomy liver failures. Okay, therefore, you must concerned about the liver factors because of if the patient had liver failures post-operatively, the survival outcome will worsen. Okay, will lower than the patient without post-hepatectomy liver failure. Okay. This is the resectability assessment in my practice. Okay. So do we talk the same language? In the other centers or the other literature said the same language with myself? I said it's no. Okay. We look at the classification of Perihilar cholangiocarcinoma. There's a lot of classification nowadays, Bismuth classification, TMM classification, memory sloan Gatling classifications, Japanese classifications, okay? We have a lot of classifications and there's no consensus guideline or no consensus about the classification nowadays, okay? I will show you some literature that we talk about the resectability. This is the paper from the Netherlands, okay, that they talk about the classification of resectability. They classify the resectability into three groups. Okay, clearly resectable and borderline resectable and clearly unresectable. This is the Netherlands group of the classifications. And for the American classifications, okay, they assess same as I told you. Okay, they will look at the patient first, fit for surgery or not, and look at the evaluation of the distant metastasis. And look at this. This is lymph node metastasis. Okay, if there's a lymph node metastasis, they will send the patients for the neoadjuvant treatment. Okay, for the local regional here, okay, they will look at the chance to achieve arterial resections, or is there any vascular resections or not, something like that. Okay, same as I told you previously. Okay, and nowadays we have a perihilar cholangiocarcinoma benchmark. Okay, I will show you. This is the benchmark kit. If you look at the paper, this paper, the benchmark case is the easy case, no vascular invasion, no HPD. Okay, so the benchmark case is the easy case. Okay, they exclude the difficult case. So Professor Endo, he proposed the resectability classifications in IHBBA in Cape Town this year. Okay, he proposed that resectability assessment in perihilar cholangiocarcinoma it will divide into resectable and borderline resectable and unresectable group, just like this. So I think uh, for the question, do we speak the same language in resectability? The answer is no. Nowadays, we don't talk the same language in resectability, but I think that in the futures, the resectability assessment will be the same in every country, in every centers, and in every surgeon practice. Okay, but in my opinion, this is the my practice for resectability assessment. Three factors: patient factors, disease factors, and liver factors. For disease factors, I will access the distant metastasis, okay, and local regional disease, okay. And the most important factor is liver factors. The, the patients will, the liver of the patient will adequate for perform liver resection, okay, because of we want the survival outcome, not technically resectability. Okay, this is the principle that Dr. Blake Candy told us many years ago. This is the most important for surgical oncology. Okay, for my conclusions, surgical resection is only chance to cure for the patient with perihilar cholangiocarcinoma. Therefore, resectability assessment is the most important step for the treatment of the patient. Okay, resectability can divide into two types: technically resectability and oncological resectability. We need oncological resectability, not only technically resectability. Okay, and resectability assessment for myself, I divide into three factors: patient factor, disease factors, and liver factors. And I think in the futures, tentative of resectability classification will divide the patient into three groups, as same as the pancreatic cancer. I think that resectable, borderline resectable, and unresectable. Okay. And this is my team, HPB Symbiotic Triple team nowadays. Okay. Thank you for your attentions and your support my channel. Okay, and I will share you a letter about the perihilar cholangiocarcinoma and any type of cholangiocarcinoma later. Okay, thank you for your attentions. Goodbye.